Hello, and welcome to this medthority.com VTE Learning Zone podcast on cancer-associated thrombosis. My name is Geoffrey Barnes. I'm from the University of Michigan, and I'm joined once again by my good friend and colleague, Dr. Alok Khorana from Cleveland Clinic. Alok, today we're going to talk about treatment of patients with cancer-associated thrombosis. And I'm wondering if you could sort of bring us up to speed. What's happened over the last couple decades to really get us from vitamin K antagonists, the way we sort of treat all of our thrombotic event patients maybe in the 1990s, up to now where we're using direct oral anticoagulants in many of these patients. How has the field sort of evolved in the last couple decades?
It's been a real, sort of having been witness to these last, several years of change. It's been a real evolution in treatment of cancer-associated thrombosis, and frankly, even the fact that we're talking about cancer-associated thrombosis is relatively new, because until the early 2000s, people just treated thrombosis the same way, whether it occurred in a person with cancer or whether it occurred in a person without cancer. What really changed in the early 2000s was, what I like to call the most successful fellow project ever, which was Agnes Lee, a very ambitious hemonc fellow in Canada, started this randomized trial of low molecular weight heparin versus vitamin K antagonists for the treatment specifically of cancer-associated thrombosis. And until that point in time, nobody had specifically addressed the cancer population for treatment. And that distinction, separating out the cancer population was key, because this is a population that has obviously a major comorbidity, cancer, which means that they also have a very high risk of bleeding, and they have a paradoxically very high risk of recurrent thrombosis. And so this population, in this population, thromboses behave in a different way than they do in almost any other population. And so what she did was, really created this field of studying specifically clots in cancer patients. That first trial, the clot trial, took vitamin K antagonists versus a low molecular weight heparin called dalteparin, and proved that dalteparin was associated with reduced risk of recurrent VTE, no real impact on bleeding. And so for the next 15 years or so, low molecular weight heparin became the standard of care. And this is not low molecular weight heparin just at the start, but for the full sort of 6 months of treatment. In the 2010s, the direct oral anticoagulants started to come on board. And initially they thought they could sort of, sneak in by just doing studies in general patients. And so you had very wide-ranging studies in all types of patients, some of which were cancer patients. But by now, because the cancer community was so used to having trials done specifically in the cancer population, everybody said, hey, we can't just expect that you did these trials in non-cancer patients and they're going to work in cancer patients who have a high risk of bleeding, high risk of recurrent thrombosis, and lots of potential for drug-drug interactions, because they're taking so many other concomitant medications. Sure. And so thankfully the industry responded, and they conducted several really well done randomized trials specifically in the cancer population, with the different products, with rivaroxaban, with edoxaban, with apixaban. And in general, what these trials showed was, was a surprise that actually recurrent VT was somewhat less in DOACs. We had already seen that it was better with low molecular heparins compared to VKAs. Going in, I personally did not expect that DOACs would be better. I was worried about sort of absorption in cancer patients and compliance and so on. But people did better with DOACs in terms of reduction in recurrent VTE, and suggesting that this pathway of sort of inhibiting specifically factor 10 inhibition seemed to be more successful in the cancer population than even in the general population. And that came with the price, increased risk of bleeding, at least in the initial trials. And the initial trials were with rivaroxaban and edoxaban. And if you look at those trials, yes, there was an increased risk of bleeding. It was driven primarily by the GI cancer population. So people with esophageal cancer, gastric cancer, to some extent colorectal cancer. The more latest, sort of the last two trials that were done, both with apixaban, did not see that increase in GI bleeding. And so that's sort of an open question that I think we should discuss, Jeff, is, is apixaban a better drug in this setting? Because there was less increase. There was actually no significantly increased risk of bleeding with apixaban, Or was it just because it was later in the course, people knew which patients to treat with DOACs and which patients not to treat, and so there was some type of selection before patients were put on these trials. But again, in terms of the evolution, vitamin K antagonists, low molecular heparins, and now DOACs, and each iteration has been better for the patient. Less recurrent thrombosis, and if selected properly, honestly, bleeding has not been a major issue in this population.
Well, we're definitely going to talk about the bleeding issues because they are front and center for many of us who are treating these patients. But I want to step back to something you said a couple minutes ago, which was how you were surprised that the direct oral anticoagulants actually had lower rates of VTE recurrence as compared to the low molecular weight heparin dalteparin in the trials. Do you think that's something specific to the drugs and mechanism of action? Is it an adherence? Patients are more likely to take an oral agent rather than an injectable? Is there something else? I mean, do you have any insight into what may have driven that in the trials?
That's a great question. Short answer is I don't really know. The long answer is that compliance and adherence is an issue, but not in trials. Typically, the research nurses are calling the patient and they're doing pill counts at the end of each visit and making sure that patients are being adherent to the prescribed clinical trial protocol. But in the real world, we and others have sort of really good data that, in fact, if there's a compliance and adherence issue, it's with the injectables. And by month 3 of anticoagulation, about close to half of patients actually drop off from taking the injectables. By 6 months, it's down to like 20% or something. So there's real drop-offs in adherence to the self-injection. But in clinical trials, you don't see that because there's just a big infrastructure around making sure that the patients are taking the prescribed medication. So I think it's both. I think in the real world, the increased recurrence rates with low molecular heparins or the higher recurrence rates with low molecular heparins may be partly because of adherence issues. But because adherence is sort of balanced in the clinical trials, I think there's also a mechanistic reason why people are doing better with DOACs than they are with low molecular heparins.
That's really helpful insight. So you brought up this issue of bleeding, and I know when these trials first came out, especially the edoxaban trial and the sort of the rivaroxaban pilot study that came out early on, a lot of us got very excited by the top line outcomes, but then we got concerned about that GI bleeding risk. And I'm wondering if you can help us understand a little bit, was that risk of bleeding sort of across the board? Was it only in specific patient populations? And how are you thinking about selecting who should get an oral agent versus an injectable agent sort of today as you see patients in clinic?
Yeah. So this is probably the most common clinical issue when you're trying to decide which anticoagulant to use for the treatment of an acute VTE in the cancer patient. And in a way, it's a relief that because efficacy-wise, we have no question, DOACs are easier to use, don't need any monitoring. Patients love them because it's once a day, twice a day. You don't have to be admitted to the hospital. You don't have to get, unfractionated heparin for 3 days or something and then transition on. So I just want to stress these positives because in general, this has been a win-win for cancer patients in terms of ease and reduced recurrence of VTE. You're not compromising for ease, but with a drug that has a higher recurrence rate. It actually, if anything, it has a lower recurrence rate. But this bleeding issue has come up across at least the initial clinical trials. And if you look at the bottom line, it'll say, okay, increased risk of major bleeding. But if you narrow down, actually the increased risk is just in the GI cancer patients. And you can actually narrow that down even further because it's not all GI cancer patients. That's just an easy way to sort of categorize it. But if you look within the GI cancer population, it's not the primary liver cancers, it's not the pancreas cancers, it's not the it's not the patients that have like liver metastases. It's really driven by the risk of having a luminal primary in place. And so if you have an esophageal primary and you're taking an oral drug, I think that somehow increases the risk of mucosal bleeding from that mucosal primary, and that increases the risk. At least that's sort of what we're thinking. And our practice and most people's practice, and if you look at the guidelines, I think they're saying probably stay away from luminal GI cancers, intact esophageal primary, intact gastric primary, maybe intact colorectal primary. Pretty much everybody else can get it safely. And even there's some nuance, not everybody with an intact primary will bleed. Maybe if there was sort of recent bleeding, they're more at risk for bleeding and so on. There are some other subpopulations like GU cancers patients, so bladder cancer, for instance, kidney cancer, where you see some more hematuria. That's also a sort of a type of mucosal bleeding, and that's doesn't seem to be as dramatic as GI bleeding, and is more of what we would call a nuisance bleed. But it's something you can discuss with patients. I think when we have choices like this, my philosophy is to always sort of have a fully informed discussion with the patient and say, hey, you could take a daily self-injection, probably less risk of bleeding, but this, or you could accept sort of there's going to be a slight increased risk of bleeding, but if you're willing to do that so that you don't have to take a daily self-injection, that's up to you too. So taking patient values and preferences, and I think the ISTH guidelines really stress this, taking patients' values and preferences into account is also very important. And we both practice in the United States, and as you know, Jeff, here, injectables are at higher co-pays, higher payments overall, and so that also sometimes can play a role in patient decision making, and we should make sure that patients are informed of that.
Now, you talked a little bit about sort of the different trials that have been done, and obviously they've been done with different drugs. And we should be very clear that we have not had head-to-head trials comparing one DOAC to another DOAC in a cancer-associated thrombosis population. But I'm wondering, when you look across the individual trials, do you use any of that to make decisions as to whether you might choose, say, apixaban versus rivaroxaban versus edoxaban as the three drugs that have been studied? Do you see any differences there, or do you think it was more trial design that maybe had some differences in the bleeding rates, and so it's more driven by other factors as to how you'll choose a specific oral agent?
Yeah, I would say in my practice, I take all of that into account. So for me, a GI I'm a GI oncologist, so all my patients have GI cancers. So for me, that's not a dead stop that, oh, I can't use a DOAC. I can, under the circumstances. So if you have a metastatic esophageal, but the primary was removed because they had a resection 3 years ago or something, I'm not worried about an acute GI bleed. I'll discuss it with the patient and I'll say, hey, there's a small risk. Look, probably not as high in you, but there is a risk, and make sure that they're accepting of it. And we've published I think we have some abstracts coming up at ISTH also. And so with this selection of patients for DOACs versus low molecular heparins, our institutional data is we have very low rates of major bleeding and very low rates of recurrent VTE, less than 5% for both. So 95% of patients, if you select these drugs properly, educate patients properly, over 95% of patients will not have major concern for recurrent VTE or for major bleeding. I think that's a really important win for cancer patients. We don't celebrate our successes often enough in medicine. And, this is a success. We really transformed the field from something really unwieldy. Remember the INR monitoring days and, all the interactions with 5-fluorouracil and all of that to now where it's easier and more effective and for the most part safer. I don't know that I distinguish adequately between the different agents. To be honest, I don't use edoxaban because it has that lead-in for a low molecular weight heparin. And so it's usually between Treva and apixaban. And most of our patients have a formulary decision already made by their insurance company. And so we are sort of forced to use whatever their formulary allows. I'm grateful for the apixaban data because it looks like you can use it successfully. There were a ton of GI cancer patients in the apixaban clinical trials, and they did not have an increased risk of major bleeding. So I think to me, that's reassuring that if you select patients properly, you can avoid GI bleeding. But I also don't want to be blasé about it and say, well, nobody in the apixaban trials had it, therefore apixaban's a different drug than Riva or edoxaban, and therefore I don't have to worry about GI bleeding at all. I think that's sort of too far. We don't have a head-to-head Riva versus apixaban trial, as you pointed out. And so when I think somebody with an intact gastric primary, I don't think I would risk a DOAC unless they sort of absolutely insisted or there was severe financial considerations that made me that they sort of beg to use it. So I think it's very individualized. It's very patient driven. It's very patient preference driven. But again, that's as it should be. And it's great to have options, and it's great to have all these very effective options.
Well, as you have mentioned a few times, our patients with cancer are some of the highest risk for thrombosis, and it has really bad outcomes for them. So getting appropriate treatment is really important. But we also know that these are often very challenging patients to treat because of a number of other factors. And I want to ask you about two situations in particular that come up that can maybe challenge how we think about treating these patients. So the first would be that many patients with cancer are getting chemotherapy agents and radiation treatment, and it may impact their risk of bleeding. And I'm thinking in particular about thrombocytopenia. And I'm wondering, how do you think about thrombocytopenia and choosing to treat somebody with an objectively identified VTE? Do you have a threshold at which you do or don't give anticoagulants? Do you change the intensity? How do you think through that?
Yeah, so for my clinical practice, as I mentioned, it's mostly GI cancer patients. Solid tumor patients, we don't see profound thrombocytopenia. Most people have platelet counts of 75,000 or higher. And in that population, I think I don't actually even consider that sort of really thrombocytopenic. So I don't make any different decisions than I would otherwise. And I think it's probably safe to continue that strategy even until 50,000 or so. I think once you get under 50,000, you are at increased risk. For sure, you're at increased risk of bleeding. There are some nice ISTH guidance statements around this. They're not evidence-based just because we don't have a lot of evidence. But I would say, less than 50,000, you could consider dropping to the prophylactic dose. Less than 30,000, I would get very uncomfortable with anticoagulation, and that might be a time you would consider a temporary IVC filter, or if it's been sufficient time since the blood clot, maybe just skip the drug for a little while.
So the other situation that I see come up from time to time is that a patient with cancer is just not able to take oral food or even pills by mouth, and that really presents a problem. And I'm wondering if a patient has a feeding tube in place, or if they're just not taking an adequate oral intake of food, does that sway you away from using the orals and towards more of the injectables, or are there strategies that you can still get the orals in? How do you approach those patients?
Yeah, that's a tough situation. I think the context of that situation is also important to sort of think about. It's typically when you get patients in that with those types of situations, it may be that they're heading towards comfort care or hospice. So we have to take that context into account as well. And there's good data for continuing anticoagulation in palliative care and hospice, and then there's good data for not doing it either. So I think again, it's like everything else, it needs to be individualized. I would say in general, that scenario, I would prefer switching to low molecular heparin. It's just easier. It reduces sort of the stress on the caregiver. It reduces your concerns about sort of absorption of the drug, because the feeding tube might not necessarily be a gastrostomy. It could be a jejunostomy or something. So I worry in that setting about whether I'm sort of properly anticoagulating the patient or not. So I think it's fair to sort of switch over to low molecular heparin at that point.
Great. Well, as we've come to the end of this episode of our podcast, you've highlighted a number of times just how important it is to identify and then treat patients who have cancer-associated thrombosis. And I'm wondering, do you have any big take-home points? If you had one message that you wanted to send to your fellow clinicians about, either the diagnosis or the treatment of cancer-associated thrombosis, what would that be?
I think it's really important that we educate our patients, and I don't know why that isn't happening. We see it's sort of a weird blind spot where we see blood clots happening so often in our cancer patients, and we just assume it's sort of, natural, and not think about, hey, some people are more at risk. I should really tell those patients, hey, if you get a swelling in your leg or chest pain, shortness of breath, whatever the warning signs and symptoms are, and maybe I can prevent it, and I should be thinking about primary prevention. And so, again, recognizing there are multiple competing priorities when oncologists are speaking to cancer patients, and not to say that they should replace the number one priority, which almost always is the cancer and what's happening with the cancer and the treatments for cancer. But at least it should be in the top 5 things that you talk to people about. So I think there's a call to action here. It's to take this seriously. It's an important complication of people with cancer. In many settings, it is preventable. And we didn't talk much about the hospitalized setting, but in the hospitalized setting, in the post-operative setting, possibly in the in the chemotherapy setting, it is preventable. But you're not going to prevent it. You're not going to do any of those things if you don't think of it as a problem that's at least partly created by the drugs we're giving and the treatments that we're doing for cancer patients. So I would say that adjustment in how we think about this, rather than as something, oh, that just happens, but thinking about it as a problem that's, to some extent fixable. I think we need to change that mindset a little bit.
Yeah, this is a priority, and it's something that we owe to our patients to help make them aware of and think about the best ways to prevent and treat. That's a great way to, I think, end this this podcast and this great call to action. Well, Dr. Alok Khorana, thank you for joining us. I want to thank everyone for being on this podcast with us today. I encourage you to check out medthority.com in the VTE Learning Zone for more podcasts in this space. My name is Geoffrey Barnes, and thanks for being with us.